Let me welcome everyone to OBGYN Providers Night. We have a full slate of our providers to talk about the experience on labor and delivery. For those of you in Hershey with a impending storm out there, this is, lightning. This is an excellent place to get shelter from the storm, but I can guarantee you that your experience on labor and delivery will be far above shelter. It will really be an outstanding, even luxurious experience. As many of you are aware, we have opened a new labor and delivery in November of 2020. It is on the 7th floor of our children's hospital. And one of the inciting events for this was that we wanted to be closer to the NICU, and we are very close to the NICU. It's right one floor above us, and I think that's just led to better care. It's led to better access for our patients to the NICU, and I think overall a better patient experience. What we've been trying to create as we've moved into this new space is really to provide a full spectrum of providers to meet every patient's expectation. So we have a nurse midwifery service you'll hear about. We have a family community medicine obstetric service. We have our women's health obstetric service. And then for all of the services, we have our maternal fetal medicine service. And again, on top of that, our NICU, we have dedicated OB anesthesia providers 24/7, 365 to provide you with relief during your obstetric experience. So with that, I'd like to get into the providers and thank you for attending this session. Our first presenter will be Dr. Dennis Muse, representing our NICU. So Dennis, take it away.
Thank you, Rick. So I want to tell you about our NICU, and I hope it's a place that none of you have to see, and tell you about some people that work there, people I hope you do not have to meet. I'm the medical director of our NICU, our neonatal intensive care unit, and we have a tall order. We want to familiarize you with what a NICU is and what specifically about Hershey's NICU in about 10 minutes. So that's going to be impossible to accomplish fully, but I do want to hit on the following points and answer any questions that you may have. So with your permission, what I'd like to do is just talk in general about what is a NICU and what's special about ours. Talk a little bit about the babies we care for, who needs a NICU and what goes on in there. What do we do for those babies? And then I'm sure you're interested in what life is like for parents of babies in the NICU. And finally, just to touch on going home. So as Dr. LeGros said, we're in a new NICU and there's a new L&D space, and that was opened in early November of last year. So we're coming up on a year now. It still looks new, feels new, but we know where all the controls are. The new car smell is still there. And it is very, very nice to be one floor directly above labor and delivery. That allows us to come down and talk to prenatal moms. It allows the obstetricians to come up and follow up with babies, but it really makes life much easier for moms and dads who have to traffic back and forth between the units. On your right is a picture of a happy day. That was the day we actually moved over 30 babies from our old NICU over a substantial distance to our new NICU. Next slide. So we kind of regard the NICU as a physical space. It's full of equipment, it's full of people, but you could actually look at a NICU as reassurance. As I said, it's a place that most parents aren't too familiar with. It's a place we hope you don't have to come. But if you need us, we do have a very special resource here at Hershey. And this is from moving day, and you can see somebody being tucked in. I will tell you that the facilities are first class. They're a significant upgrade over what we used to have, and they rival any NICUs that we visited while we were in the planning phase of this. You could get a sense for the motif. The colors are friendly. It's a nature motif throughout the children's hospital, and we're the canopy at the top, and we have like a bird and nest theme throughout our NICU. And if you look at the left-hand side of that corner, you can get a glimpse of a view far down below. We have the best views in Hershey, bar none. What we're proud about and what distinguishes us is we're the only level 4 NICU in central Pennsylvania, between Philly and Pittsburgh. What makes it level 4 is we can provide all of the services necessary for any neonatal illness that comes along. But and some of our surrounding hospitals do a very good job of that as well. But we have specialists, we have surgeons, we have cardiothoracic surgery, we do heart surgery on babies. We have heart-lung bypass called ECMO, which we can support babies whose lungs are too sick to breathe. And we have a number of other specialized services that distinguish us as a level 4. We're also the only certified children's surgical center in Pennsylvania. This is a special accreditation given to make sure we meet standards for outcomes and processes regarding surgical care of our babies. As a facility, we have 56 beds. Most of them are individual rooms where parents can stay in the room as long as you'd like. There are no specific visiting hours for our families. And currently under COVID restrictions, there are 2 visitors a day, but parents can identify up to 4 other people who can come and visit with the babies. We have 29 of our rooms are individuals. We have 4 twin rooms and 1 triplet room as well. And we have a geographic area where we take care of the smallest of the babies who are about under 1 kilogram or 2¼ pounds. They get special care by people who are special training in those tiny baby needs. We have a complete roster of medical and surgical services, and we have a number of other services. I plucked one of them out. It's a milk lab, which is a highly specialized area where we process mom's milk and store it for use and mix formulas and supplements as necessary. Nutrition is the key for a premature baby getting out of our unit, and so we spend a lot of time with that. And finally, what really matters to you is how does my baby do in terms of survival, in terms of quality of survival. We belong to national databases and we are excellent performers across the board. Next. So the geographic space is important. It's filled with technology. You can see this is a very busy looking picture. This is a baby who's in there, and you can see there's just a plethora of equipment around this baby, and it can be a very, very daunting kind of experience for a mom or a dad coming in, particularly the first time to see a baby. This is so different an experience and exposure than what parents are thinking of in terms of their full-term Gerber-looking baby. Here you can see nurses and respiratory therapists settling a baby in. Again, you see the nature motif behind the baby and the colors. The rooms are large, which is great for getting the necessary equipment in. Next slide. And just to prove there was a baby in there, here's the little one saying hi to us. Next slide. The care team, you'll meet so many people. That's another daunting job when you first come to the NICU. We work in teams, and there's so many people to get to know, but you will know us and we'll know you, and you'll see that a rapport develops quickly, and we function very, very much as a team with you as at the lead of that team. We have excellent neonatal nurses. These are the people you'll probably get to, if you need to be in our unit, these are the people you'll probably get to know most intimately. They're there at the bedside, round the clock, and they're obviously interested in being there to take care of babies, and they work very well with families. We have neonatologists, who are pediatricians who have done extra training to take care of critically ill babies. We have nurse practitioners, physician's assistants. We have people in training like neonatal fellows, respiratory therapists, and all kinds of medical and surgical consultants that come as necessary for the baby. But there's a lot of people who work either on rounds or behind the scenes with us. Nutrition, we have a specialist in nutrition. We have a neonatal pharmacist, care coordination, social worker, physical and occupational therapy, We do music therapy with the kids. We have lactation specialists. And these are just a few. And these are people that, if you're with us, you'll get to meet them along the way. Next slide. The most important people, obviously, are your babies and yourselves. And here are just a couple of our parents spending time with their babies. We like to try to make this as least foreign environment and experience as we can for you. It's difficult to have a baby in a NICU, but we try to get you acclimated right away. You're the parents, what you see matters, what you think matters, what you want to do with your child matters. We, of course, give you direction and opinions, but we all function as a team. As I said, there's no visiting hours per se. We like to have you spending as much time as possible with your baby. We understand that's a challenge for some. Some families live a couple, 3 hours away and they have jobs and other children, other responsibilities. But the single private rooms really facilitate having parents stay with us. Next slide. Here's just a couple pictures that give you an example of what goes on in our unit. The little one on the left has a plastic tube in the mouth that goes into the airway. That's an endotracheal tube. Many of our babies, particularly the premature babies, do require help with their breathing, and they might be on a ventilator with the breathing tube in, or the baby on the right, you could see has CPAP. Many adults and older children might use CPAP for other reasons, but CPAP is a very common thing for us to use. You can see that each baby also has what looks like an orange tube coming from the nose or mouth, and those are for nutrition. Premature babies don't know how to suck and swallow till they're past 34 weeks, but we try to get busy right away with your milk, if at all possible. Your mom's milk is the best, and we definitely try to go with that. We do have a donor milk program if we need to use that as a bridge, but babies don't know how to eat until they are at least 34 weeks and off of respiratory support, so they get tube fed. You see the little one on the left has an IV for IV fluids and nutrition, and that's very common as well. And the baby on the right, we're looking through plastic walls. That baby's in an incubator, and most of our little ones do require help staying warm and comfortable. You can see that the baby on the right is clothed, and there's all kinds of developmental aids, like a soft beanbag kind of cushion under the baby's head. We try to take the technological edge off of the NICU and make this a developmentally sound place for the babies to be. Next slide. And we're very, very enthusiastic about skin-to-skin care in the NICU. And here are a couple of moms. You see that their babies are still on respiratory support. In the old days, the babies stayed in the beds. You felt lucky if you got to touch them. That's not how things work today, fortunately. It's been shown that babies feel better and they're more physiologically stable when they have this nice skin-to-skin process going on. And what we like to do is that, and dads, as a male doc, I always try to look out for our dads and make sure that they get time for skin to skin as well. But once the baby's settled in, we like you to enjoy, at least an hour just holding your baby and keeping him or her comfortable. And we also have a reading program that's up and running now. So a lot of parents read while this is going on. Next slide. This is the last slide. And the questions that come to mind are, is my baby going to be okay? Is my baby going to have leftover problems? And those things, of course, depend on why the infant's in the NICU in the first place. About, over half of our babies come in because of prematurity, but other things bring even full-term babies in, like a rough start, after a difficult delivery, an infection, a congenital abnormality of the heart or the lungs, or a neurologic problem. So we see all kinds of babies, and how long they stay and how well are they going to do depends on what the underlying diagnosis is. But one of the things that always comes up is how long will the infant stay? And that varies a lot, again, by diagnosis. But if you have a premature baby, he or she is probably not going to go home before they're about between 35 and 37 weeks of gestational age. And what makes a baby ready for discharge? Previously, long time ago, there used to be a weight cutoff. Some NICUs used about 5 pounds or a certain age. That's not so much the case anymore. You have to be big enough to fit in a car seat, but we want the baby to be stable from a breathing standpoint, not having any real long pauses in the breathing, be able to stay warm and feeding by mouth enough to continue growing. There's all kinds of preparation that goes into this. Going home is indeed a red letter day. It's exciting. It's what we work towards. It's what parents want. But there's potentially a lot of anxiety attached to that day. We try to start from day one to make you feel like you're the caregiver. You get involved with the baby's care. We want you to feel as prepared as possible going home. Some of our kids do have special needs. Most don't. Most go home and have fairly standard health maintenance, but we do sometimes have kids who go home on medications or oxygen or even tube feedings. And it's important to know that we interface with the community pediatricians and family medicine people to make sure that there's a seamless transition from the NICU to outpatient follow-up that's always going to be necessary. I think I'll stop there and answer any questions.
There are questions.
I'm sorry, Lori?
No questions right now.
Yeah, I don't see any. So if I may, I'll introduce our next speaker, Dr. Chris DeAngelis, who's going to tell us about the Women's Health Unit.
Thank you for the introduction and welcome to everyone. I'm so grateful that you joined us tonight. I've been delivering babies since 1998, and I'm one of our women's health obstetricians, joined the faculty at Penn State in 2017. Thank you, Lori, for bringing up my slides. So right up front there is a picture of our beautiful medical center. If you could go to the next slide, please. Okay, so first thing, just want to review some things that you want to think about before you go to the hospital. First thing, pack a bag. I usually recommend to patients when you're 36 to 37 weeks, it's a good idea to get some stuff together because, you know, sometimes labor always happens in the middle of the night. It's not the best time to be getting things together. So we have wonderful resources at Hershey, and there's not a whole lot you need, but a couple of tips I always give my patients. Our pillows have to be OSHA approved. So they're plastic, so we can sterilize them. So if you're particular about having a comfortable pillow, you might want to bring your own from home in with some old pillowcases because labor can be kind of a messy business. I had some comfortable clothes in my bag after I delivered, just some new comfortable pajamas and obviously clothes to go home in, some flip-flops to walk around in. We have Wi-Fi, so a lot of people like to bring, you know, a computer or iPad or something in. If you have any music that's particular to you, sometimes it's nice to have nice music while you're laboring. We do have XM radio with a couple stations available while you're laboring, but some couples like to make their own playlists. All the resources for your baby will be provided except an outfit if you want to have photos done in the hospital. So that's you don't need anything for the baby, and you don't need to bring a breast pump in. If you need assistance with a breast pump, we provide them in the hospital. COVID testing, we do test all of our patients. There's been, as everyone is aware, an uptick in cases in our region as well as many other regions, even in people who are vaccinated, unfortunately. Although it's less common, it's still possible to have an asymptomatic or just very minimal symptoms. So we are testing everyone. If we know that you're going to be admitted for a C-section or a planned induction, we'll typically have you go about 3 days before you're due to come into the hospital. However, you know, labor isn't always planned. So if you didn't know that you were going to be coming into the hospital to have your baby, we'll just test you when you arrive. So when labor happens in the middle of the night, as it always happens, you're going to call whichever office you've gone to get your OB care, whether it be through Women's Health or same thing for our patients who are seen by our family and community medicine obstetricians. You're going to call in, and if it's the middle of the night or the weekend, you're going to get our triage nurses who are very helpful. They're going to ask you some questions and give you good advice about whether or not it's time to come in. It's very frustrating for patients to come in and be sent home. So we like to do our best to make sure that it's really time to have the baby. Although again, our doors are open 24 hours a day, 7 days a week, and we are happy to see you anytime. You're never a bother. And any concern you have, please call the office. Can you go to the next slide, please? So what to expect once you get onto labor and delivery. Our admission process is relatively streamlined. Once you've called in to the triage line, our staff on labor and delivery will be notified that you're coming in. So they'll have a room ready for you. Typically, you're going to come in through the main entrance of the hospital or the emergency department. Those are the two areas that are open 24 hours a day. Our new labor and delivery units in the children's hospital, so that's open during regular hours. In the middle of the night, you might come in through the emergency department. So when you come in, you're going to get admitted and get a lovely gown to wear. The nurses are going to take some information from you regarding some of the preferences you have during your labor after you deliver. We use a team-based approach to the care, which was one of the things that I love about Hershey Medical Center. There are, including myself, 9 obstetricians that typically care for our patients on the labor floor. We have a group of 20 residents who are outstanding and are a tremendous help in caring for the patients. And then we work as a team with our colleagues in family and community medicine. You'll meet Dr. Lutz Cannon later. They are wonderful. So we help each other out if one of us is tied up and needs help. And my anesthesia colleagues, I mean, it is wonderful to be at a place where we have so many outstanding healthcare workers. I've been in places where, you know, you're literally the only person there, and that's not a great feeling. So I really appreciate that we work together. Monitoring during the labor process can depend a little bit on the situation. If you come in natural labor and we do some monitoring and baby looks good and it's your preference to move around or be out of bed, we can accommodate that. And I think our midwives will cover that a little bit later. If it's a situation where we're using medications to help your labor or an induction where we use medications, we tend to monitor things a little more closely. Initially, we start with external monitors. They're not painful at all. They're just a little plastic monitor that rests against your abdomen. One of them measures contractions, one of them measures the baby's heartbeat. Sometimes as the labor goes on, if your water breaks, we will use internal monitors if we're not picking up the contractions or the baby's heart rate very well. There are different medications we use during labor. I'm not going to cover any of the anesthesia medicines because Dr. Poe is going to go into much better detail than I could regarding those. But we do sometimes use medications to help the labor along. Sometimes women aren't having strong enough contractions, so we'll use medications to make the contractions stronger. We always review that with patients and let them know, you know, if we need to use these medicines and explain why we're doing what we're doing. If you need a C-section because the labor is not progressing or there's a complication with the labor, we can do that. We have C-section rooms right on labor and delivery, so you don't have to go to a different area of the hospital. And we can have your support person in with you. Typically, once you're all prepared for the C-section, we'll call them in. They can bring a camera, and we still try and do the skin to skin and try and recreate it as much as we can with a vaginal delivery. With a vaginal delivery, there'll be a couple people in the room. Of course, you're going to have your obstetrician or your family community medicine physician with you, and usually 1 or 2 residents if they're available, and typically 2 nurses, 1 nurse that's been with you the whole time you're laboring, and 1 nurse to help care for the baby. So that's typically who's going to be in there. You know, it's always an exciting time. We always say everyone wants to come for the birthday party, and our staff are great about taking pictures for you. Next slide, please. So once you've had your baby, what should you expect after you've delivered? We have private postpartum rooms that are very lovely. Some of our rooms are on the same floor as labor and delivery. Some are on the floor underneath labor and delivery, but they're all relatively close. Both of those floors have a nursery as well. Every day you're going to see members of the team that took care of you while you were in labor, the obstetrical team. Typically the attending and the resident will come around to check in on you. We kind of are early morning people, so we typically will come in rather early, around 6 a.m. Unfortunately with a baby, you're usually up at that time anyway. So I'd say more often than not, we're not waking you up. You're already up with the baby, feeding the baby. The pediatric team will come around every day as well to see the baby. We have lactation consultants that are wonderful. They come around and meet with moms who are breastfeeding to give them some tips. All of our nurses are also trained and are very helpful with breastfeeding. So if the lactation consultant isn't available, I don't want you to worry that there's no one to help you. All of our nurses are very skilled and extremely helpful. If you have a male infant and you'd like them circumcised, we typically do that prior to discharge. I'm not going to go into that because I believe Dr. Lutz-Cannon is going to cover the circumcision procedure, but we try to do it the night before if possible. So it gives a little time to make sure that baby's healing nicely. There are certain situations where sometimes it might be delayed and done outpatient, depending if the baby was born premature or if there's any other complications regarding the baby's care. And then discharge instructions are provided the day that you're leaving. We actually have pre-printed instructions that some of our residents worked on that are very thorough because again, we sometimes are coming in at 6 a.m. and you haven't had coffee and you're barely awake and we're talking to you about, things you can do postpartum and it might be hard to remember some of that. So we have it all nicely written out and I always encourage patients, don't hesitate to call again your office once you go home. If you have a question, we're always happy to see you or just to help you with any questions. We also can provide lactation support. Once you go home, we have lactation consultants that work out of the office. Next slide, please. All right, I think I'm done. So I'm going to turn it over to Dr. Miller, one of my colleagues from pediatrics. Thank you all again. And I'm happy. Oh, wait, I guess I can answer questions now. I think we have questions at the end, but if there are any questions now, I'm happy to answer them before Dr. Miller takes over.
No questions yet, Dr. DeAngelis. Thank you.
Okay, I'll be available at the end. Thank you.
All right, good evening, everybody. My name is Jennifer Miller. I'm one of the pediatricians at Penn State. I'm the medical director of the newborn nursery, and I also work out of the Hope Drive pediatric office. Next slide, please. So I'm here to talk a little bit about kind of the opposite of what Dr. Muse was talking about. What does care look like in the regular newborn nursery, the place that wants to see you and wants to have you come and spend time with us? We also sort of function in that team approach. So in the pediatric care of the newborn, you'll see an entire sort of team of doctors for the baby. There'll be an attending physician who's in charge of the baby's care. We have pediatric residents as well as family and community medicine residents who help us on the team. We have medical students, and occasionally we even have PA students with us. So you may see a relatively large number of folks coming around to see the baby. And we usually round a little bit later than OB does. Pediatricians generally get ourselves around sometime between 8 and 11 in the morning. So you'll see us every day coming around in mass. Next slide. So when will we come and see your baby? It depends a little bit on when the baby is born. Certainly if there are any sort of minor concerns, things that would not bring your baby to the NICU, we would come in and see the baby in the delivery room. In general, though, we try to give you as much privacy as we can in the first several hours of postpartum life. So it may be several hours after the baby's born. It may even be the next morning that you actually meet the entire pediatric team. Next slide. In our facility, we generally have babies stay with their families in the rooms. As Dr. DeAngelis said, we have a newborn nursery that's fully staffed and fully equipped on both floors. Where we take care of babies, but we really don't like to see babies in those nurseries unless they're having their circumcisions done, if there's some sort of procedure that's needed, or if we have a family that's really just too exhausted or ill to take care of the baby, then absolutely your baby's more than welcome to come and hang out with us in the newborn nursery. But in general, the expectation is that babies will stay in the room with their families. So, the days where folks would come and look through the window at the sea of babies that, is lying in the newborn nursery, those days are gone. And for the most part, our newborn nursery is empty these days. Next slide. So what is the pediatrician going to do sort of when we come into the room? We do review all of the prenatal records, and we will sort of comb through and see if we can find any particular red flags that may pop up during your pregnancy, and make sure that we have discussions with you about sort of what has been told to you up to this point, and what sort of expectations do you have for any red flags that had popped up along the way. We'll examine the baby, obviously every day. Newborns get a lot of screenings done when they're first born. We screen things like hearing. We look at oxygen levels. We screen babies for jaundice. There's something called a state newborn screen where babies are tested for a real myriad of genetic diseases that can affect them down the road. We screen babies for low blood sugar, which is fairly common, especially if your baby is born a little bit early or is on the smaller side. So there's lots and lots of screenings that get done for newborns. And we try to do our best to make sure that everyone understands why they're important, what the results of those screenings are, and what they mean for baby going forward. Next slide. One of the most important questions that we're going to ask is, who is the baby's doctor going to be after you go home? This is something that we really recommend families give some thought to before the baby actually arrives. It's not uncommon for families to come and deliver and not know, but it makes things a whole lot easier when you already know who the baby's doctor is going to be, because we can help you get the follow-up appointment set up. If the baby is going to be seen within our Penn State Health system, we will make those appointments for you. If not, we will have families give a call to the private offices where they're going to be going. But it is really good to have those decisions made before you arrive. Next slide. So as Dr. Muse talked about, nutrition is one of the most important things in the NICU, and it really is in the newborn nursery as well. Feeding is the name of the game in the newborn nursery. It's the biggest task for families that spend time with us. We try to be supportive of whatever decision is best for your family, whether it be breast or formula. We weigh babies daily, discuss with families how the feeding is going, how breastfeeding at the breast is going, how pumping is going, how formula feeding is going, and try to make our best recommendations about how we feel like feeding should move forward. As Dr. DeAngelis said, we have lactation consultants who are in-house. They are there 7 days a week. They are wonderful. They're an excellent resource. We go to them when we're a little bit stumped about what to do with babies. So we highly encourage families to take advantage of their care. Next slide. As I said, we see families and examine babies every day. Sometime between 8 and 11 is when you can expect us. And obviously we'll address any concerns that you might have. Next slide. Going home from the newborn nursery, for an uncomplicated baby who has been born by a vaginal delivery, it's usually someplace between 24 and 48 hours. In general, babies are expected to stay at least 24 hours in the hospital, mostly because some of the screening things that we need to do are not particularly accurate until babies are at least 24 hours of age. For families who've delivered by C-section, in general, they stay a little bit longer. It's usually somewhere between 48 to 96 hours. There are a couple of things that we require, though, for babies to go home. We absolutely want baby to have a safe car seat to go home with, and our nurses will sort of check your car seat, make sure there's no recalls, make sure it hasn't expired, all of those things. And then we will also assure that you have a safe place for your baby to sleep, whether that be a crib, a bassinet, a pack and play, and we have resources available in the hospital if families are unable to provide those things. We will absolutely help with that as well. Next slide. As Dr. Muse said, everyone hopes that families do not need the NICU, but I really sort of look at them as insurance. They're there if we need help, if a baby has a problem who is in the newborn nursery, if a baby has a problem in labor and delivery. I really look at our relationship as very collaborative, and they're always there if we need their help along the way. Next slide. I think that is it for me. I certainly welcome any questions now or later. And with that, I'll turn it over to Dr. Poe, who's going to talk about OB anesthesia.
Hi, good evening. My name is Dr. Wilson Poe. I'm from the Department of Anesthesiology and Perioperative Medicine here at the Medical Center. I'm glad to be here, be part of the OB team providers. My goal tonight is to give you an overview of our obstetric anesthesia services in about 5 minutes or less, so I can give you more time for questions. As you can see from my slide, we're a big department, mostly composed of board-certified anesthesiologists and resident physicians who are on their way to becoming board-certified anesthesiologists on their own. We also have nurse anesthetists. However, they don't work on the OB floor, so you probably won't see them. Next slide, please. Our department offers a dedicated in-house obstetric anesthesia team, which are immediately available 24/7. That means we can provide prompt care whenever the need arises, because everybody knows nobody delivers after midnight. Our team is composed of faculty attending and residents. Next slide, please. We normally see you on the floor when you get admitted. However, even before that, we do participate in monthly childbirth classes. These are offered or provided by our wonderful OB nurses. On our part, it's not really a formal class, but it's a chance for us to meet in a more peaceful and subtle way, because most of the time when we get to meet each other, you're in some kind of distress. So during the class, it's actually a chance for you to ask questions about anesthesias and make it more relevant for your case. Also, we have anesthesia preoperative evaluation clinic. This is, we get referrals from our OB colleagues for patients that might require special attention. Most of our patients are referred from the obstetric clinic because they have a problem that they encountered the last time, or something that might anticipate having a problem during delivery. So we do meet them before they're in the OB floor. Another good resource that we have is the chronic pain clinic for patients who suffer from chronic pain and who use chronic opioids. This is a very good resource that we also have and use. Next slide, please. Our anesthesia preoperative clinic is located in the University Physician Center. One is on the first floor and the other one is on the third, and they're both close to the hospital. Next slide, please. So providing pain relief during labor is one of our best services that we offer. That's my old slide. Hopefully not during my time or my son's time yet, but for now, the gold standard is a labor lumbar epidural, which we can provide to provide relief. Gold standard in terms of safety for both mother and baby, and gold standard in terms of efficacy, providing relief. The difference is is mostly seen almost like night and day. Next slide, please. For any reason, either medical reasons, for example, bleeding disorders, or technical reasons, young women who had scoliosis when they were teenagers, had Harrington rods or hardware in their back that couldn't have, that make it impossible for us to put an epidural in, or pregnant women who had coagulation problems such as hemophilia, then we're not able to put an epidural in, we can offer an intravenous infusion using remifentanil. Remifentanil is a special kind of opioid. It's a short-acting opioid that we can be used as an infusion, a precision-controlled analgesic that you can push a button and it could provide relief. Of course, it might not be the same as effective as having an epidural. Next slide, please. So everybody comes in and expecting a normal delivery, but sometimes the circumstances different. For any obstetric reason that you might require operative or cesarean section, either because of the baby's condition or with regards to the mom's condition, we can offer neuraxial anesthesia. This we do by placing an epidural, a spinal, or a combined spinal. In layman's term, it's basically giving medicine close to the spinal cord that would make you numb from waist down, from the nipple down, and that would make you be able to have surgery while you're awake and see your baby right after you deliver them. Your spouse is normally, or loved one can be beside you when we do this. Another way, or if it's really emergent and the baby needs to come out, we do provide general anesthesia. And as with any other emergency, you have to be asleep with this, and we secure the airway by putting in an endotracheal tube. The last one is regional anesthesia, for which we use local anesthetic injections to provide pain relief after surgery. Next slide, please. So just like was mentioned before, we do have a brand new OB suite that opened in November 2020. As you can see from the picture, I think the first C-section was done on November 8th. And these are the providers, doctors that were involved. Next slide. We do have brand new operating rooms that we can use if you need a C-section or any other surgical needs. For example, a CERCLAT, a DNC, surgical repairs that you might need after delivery. One of the operating rooms is a negative pressure room, obviously due to COVID. And close to that operating rooms, next slide please, is our PACU or recovery room, which has 3 beds that is next to the operating room, so we can watch over you after you deliver. Next slide, please. I guess that's it for now. I'm available if there's any questions. If not, Dr. Lutz Kanin from Family Practice is next.
Thank you, Dr. Poe.
Good evening. My name is Andy Lutz Cannon. As Dr. Poe said, I'm from the Department of Family and Community Medicine, and I'm here to talk briefly about what we offer in terms of obstetrical care for patients that choose to come follow in our practices. Next slide. So this sometimes comes as a surprise to patients to learn that there are family doctors in the community that are still providing prenatal care and delivery care, harkening back to sort of the old days of the general practitioner. But we do have a robust service through our department. And so we provide full outpatient prenatal care, generally for low-risk pregnancies, but we are able to handle some complications of pregnancy, diabetes, hypertension, and do this in a collaboration with our colleagues, both in women's health and with the maternal fetal medicine physicians, the high-risk specialists. Our physicians provide 24/7 coverage of the labor and delivery unit. So day or night, there is someone that is available to come and take care of you. You won't have to worry if it's 3 o'clock in the morning about not seeing one of our providers. Both myself and Dr. Ramirez do have extra fellowship training in surgical obstetrics, and so are able to help assist with your C-section, whether you're needing a repeat C-section or if something is changing in your labor course that would require you to go have a C-section. We then do double duty and round on the babies over in the newborn nursery and take care of them as well in anticipation of discharge if you are electing to have your baby followed at one of our office. And as Dr. DeAngelis had mentioned, we do also do circumcisions. We will do those on our patients in the regular nursery, and then we are also consulted by the NICU. So if your baby is up there and you would like a circumcision prior to him going home, that is certainly something that we can do for you. It's actually kind of fun. Usually by the time they're calling me up there, that's good news that your baby's getting ready to go home. Next slide, please. So there are currently 6 of us in the department that provide labor and delivery coverage, and I want to say about 8 or 9 more in the department that do prenatal care and then hand off the delivery aspect to our group. You can see we have providers spread across the region. Dr. Malunik, Dr. Henning, who a lot of people know, he's been around for a very long time. Dr. Hartman, Dr. Ramirez, myself, and Dr. Crode. Next slide. So a lot of times people will ask, what's the difference? What level of care am I getting? Why would I decide to pick family medicine versus women's health? So we use what I would consider to be more of an old-fashioned approach, where you get the same provider throughout the course of your pregnancy. We try to maintain that continuity with our patients. We also do come in for our own deliveries, whether that's day or night, provided that we are available to do that. And we'll even sometimes follow you postpartum in the hospital, but then definitely back in the office, you'll come back and see us. And so some patients prefer this approach. For other patients, the convenience of the women's health department is what is preferred, or the expertise that they bring. But we, like I said, we work in close collaboration with our colleagues. We have a variety of flexible locations. So sometimes patients don't have to drive as far to get to our offices. You can see our locations there sort of spread across the region. Definitely the West Shore and Camp Hill and Mechanicsburg is a place that we're looking to expand as we look to the future. And then we do offer care for the entire family. So your spouse, your baby, for you, if anybody is needing a primary care doctor, or if you have any medical issues, if there are any kind of long lasting complications from the pregnancy, which hopefully there are not, the vast majority of times there are not, but we can see you, we can care for your baby, we can continue to follow you maybe through subsequent pregnancies. Next slide. Like I said, we do circumcisions, both us and the women's health providers in the newborn nursery. This is an elective procedure, so it's usually done for either cultural reasons for the parents or for potty training purposes. We do typically let the babies stabilize for the first 24 hours after delivery. It lets them, get established with maintaining their temperature and getting into a good feeding pattern, allowing for good bonding, get that first bath in before doing the procedure, make sure that they're very stable. We can do this on the day of discharge. It's not something that generally holds up a discharge. A lot of people ask if we give any anesthesia or numbing during the procedure, and yes, we do. We do numb the baby with what's called, as Dr. Poe was saying earlier, regional anesthesia. We do a penile block so that the entire thing is numb. We also give sugar water to the baby, which helps alleviate pain and try to keep them comfortable during the procedure. There are rare circumstances that will come up that the baby is unable to have a circumcision period while they're in the newborn period. So we do have the availability of our pediatric urology providers to come take a look if there's any anatomical problems. And we do have a system set up to go to the surgeons as an outpatient, usually within the first month for babies that maybe need to do a little bit more growing. Primarily, sometimes the baby's up in the NICU. Next slide. So that's all I had prepared. Like I said, we are another option for your care. We'd be, pleased to take care of you and help usher you through this part of your family's care. So I will pass over to Angie Klock, who's one of our excellent midwives, to talk about what they offer.
Thank you, Dr. Lux Cannon, for that lovely introduction. So I'm one of the nurse midwives here at Hershey, and I'm going to answer a couple of common questions that we often get as far as this kind of what midwives do and how we work at Hershey. Next slide, please. So you may have heard of different kinds of midwives. Those that are employed at Hershey are certified nurse midwives. Those of us are registered nurses, and we've completed an extra 2.5 to 3 years of graduate education, specializing in the field of women's health and midwifery. And we have attained at minimum a master's degree, although some of us do have our doctoral degree in midwifery as well, or in nursing practice. Following graduation from an accredited midwifery program, we then have to sit for a board exam to become certified. And then once credentialed, we need to continue to engage in education to maintain our licensure. Next slide, please. So having said that, exactly what do midwives do? Certified nurse midwives are experts in women's health in the normal. And we provide some of the following services, although I probably don't have an inclusive list here. But we can provide preconception care, prenatal care for low-risk pregnancies, labor and delivery management for low-risk pregnancies, although we do often co-manage even moderate risk pregnancies with our physician team. We can provide postpartum care, we can do your annual gynecological exams, get your pap smears, counsel you on contraceptive use and management. Many of us can insert and remove things like IUDs and Nexplanons and write birth control prescriptions. We can also help with routine postmenopausal care. And some midwives are additionally certified for other procedures. I know that several of us at Hershey are also first assist certified to assist in C-sections if we needed to, or other things like colposcopies and things in the office. Next slide, please. Many people ask, if I choose to have a midwife attend my birth, can we have pain medication? Yes, absolutely. We will support you either way, whether you choose to have a medicated or unmedicated labor and birth, and kind of talk you through that, help answer questions along with our anesthesia colleagues a lot of times, but that's often in the form of intravenous pain medication or an epidural for pain management while you're in labor. Next slide, please. Can I have a midwife when I'm in labor if I'm not low risk? The midwives often co-manage with our physician counterparts, those women who may have a higher risk pregnancy during their labor and delivery. The physicians are going to be responsible for some or most of your care, especially certain medications and ordering things and kind of laying out the plan. And then we can assist them as needed to help carry out that plan and give you great care. Next, please. So other things you can expect from your certified nurse midwife during your labor and delivery is a team approach with you and your labor support person. We offer many things to help, especially with early labor, such as suggesting different positions and movement. We have birthing/yoga balls in all of the rooms that are available to our patients. And even if you end up having an epidural, we have peanut balls that we can use to still accomplish some of these things if you are having an epidural for pain management. We also have rocking chairs, will help you walk because we do have some intermittent fetal monitoring capabilities. We may even incorporate a shower, all things that are going to be safe for you and your baby if it's appropriate. We also utilize warm perineal compresses while you're pushing, and we use mineral oil while you're pushing to help the tissue stretch. I know a lot of women, rightfully so, want to avoid any kind of tears to their perineal areas during deliveries, and we will try to do our best there to minimize or eliminate that. We, across the board, our delivering providers do use delayed cord clamping almost every birth. There may be some times when that is not capable of being done, but almost all of the vaginal births, we perform delayed cord clamping and support skin to skin time with the baby. And I often get asked if we are available 24/7 in labor and delivery. So currently we have 4 certified nurse midwives that provide prenatal care in the clinic and also rotate through labor and delivery. We have Elaine Green, Sharon Waka, Elizabeth Newberry, and myself, Angie Clock. We have been, pretty soon I can update this slide next month, to having been a part of the labor and delivery team at Hershey for 3 years. And we continue to grow. Our eventual goal is to have a midwifery service available 24/7 for the low risk laboring women. Currently, we are there 7-day shifts per week, and looking in the very near future to hopefully add to our team and maybe start incorporating some night shifts as well. And I think that might be it. Thank you for your time. I think we have Dr. DeAngelis, who is going to help us wrap up tonight.
Thank you. Thank you all so much for attending. We really appreciate not only that you attended this webinar, but really it's no greater compliment that you're choosing us to provide your prenatal care. Having had 2 children myself, I know that I was so grateful for those who took care of me. Nothing was more important than having a healthy baby and a great experience that I'll always remember fondly. So thank you again for choosing us. And if you have any questions, I believe Lori is going to end it with our email addresses for many of the providers tonight. Don't hesitate to email us if you have any questions or concerns. And we look forward to seeing you on labor and delivery and in the offices as well. Thank you.